This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Denise Goins. Welcome, Denise.
Well, thank you very much for having me.
Yeah, we talk on our show about many different things, but tonight we're going to talk about strokes.
That's right.
And the stroke arrangements that are being put together in this part of the world, the Stroke Center, and what's going on at the Medical Center. And
right.
Why don't we discuss what you're up to these days? What is your job and what's going on?
Well, I am the Stroke Program Coordinator for Medical Center Navicent Health. And what that entails is that I do all the education. I do a lot of education for our patients. When we have our stroke patients on the floor, we want to make sure that those patients have all the tools that they need when they go home to prevent them from having another stroke. Whether it's follow-up appointments, the medications, making sure that they understand what their risk factors are. A lot of patients are totally unaware of their risk factors. So we do a lot of education with that, making sure they just recognize those signs and symptoms of a stroke. We've all heard the FAST, the face, arm, speech, and time, which American Heart Association has really pushed, especially in May, because that was our Stroke Awareness Month. So you may have seen some of the commercials on television. We had some ads even prefacing some of the movies like at Amstar 16 here. So we want to make sure that our patients are really, really prepared when they go home and they have all of the tools that they need to prevent that stroke from reoccurring. So that's just one piece of my job. The other part of my responsibility is keeping up with all of the best standard practices. That's the guidelines, the position statements, the papers that are put out, research-based papers that are put out by the American Heart Association, American Stroke Association, the National Stroke Association, to make sure that our protocols and pathways and order sets, that all of that is up to date, that we have the most current, best standard practices in the country for all of our stroke patients.
Well, okay, so it's a complicated kind of problem, isn't it? And actually, I believe we're located in the stroke belt. Is
yes,
that correct?
We are. The southeastern.
What is? You get to say.
Yeah.
I'll throw you a softball.
Throw me a softball. I'll hit it.
Hit it back. What is the stroke belt?
The stroke belt. The southeastern United States is actually made up of the largest number of strokes per capita in the country. So it's the whole southeastern United States. And if anyone ever goes to cdc.gov and you can pull up stroke and you look at it, and it's all just concentrated in the southeastern United States. And of course, that is largely in part due to our diet, our lack of exercise, diabetes, obesity, smoking, all of those high risk factors that impact our stroke patients. So Georgia actually ranks 8th in the United States for the number of strokes. Stroke is now the 5th leading cause of death in our country. We dropped down in December of 2014 from 4th to 5th. The total number of strokes, we still have approximately 795,000 strokes a year in the United States. That computes out to someone having a stroke about every 40 seconds, and unfortunately about every 4 minutes someone dies of a stroke.
And so that's a big deal, and we're in the center, the epicenter of this kind of problem, and there are many reasons for this. I'll just say, mention one of my pet peeves, if you could say that, is many people in this part of the world are hypertensive.
Correct.
And they do not take their medicine. Bad. And a lot of this is putting a system together so that people are aware of the risk they have for different kinds of problems, and the diet issues, the exercise problems, particularly hypertensive people. Really, they need to be in the healthcare system, and they need to be compliant with taking their medication.
And educating the public, because a lot of patients will come in and you'll say, do you have high blood pressure? I did, but well, why aren't you on medication? Well, I stopped it. Why did you stop it? Well, because my blood pressure was normal. Well, your blood pressure was normal because you were taking your medication. So again, that's a huge education piece that we try to take care of. We do have a process in place that we call our patients generally about 2 to 3 days after they go home, just to make sure that they've gotten their prescriptions, that they don't need anything else. And then we've also, with our Navicent Health Rehabilitation Hospital, has started an acute post-stroke clinic. So we are calling patients, particularly those patients that go home without any services. Maybe they were too well to qualify for any services at the time of discharge, so those are the ones we're tapping into. They're bringing them back in to the rehab hospital, and they're actually being evaluated by the physiatrist, physical therapy, occupational therapy, speech therapy. There's a pharmacist available in case there is some issues with medication compliance, as well as a dietitian in case they have dietary needs. All of those evaluations are compilated and kind of a report is written, and then it's forwarded to their physician, so that if those patients need any services at that point, we can actually assist them with any care that they may need once they've gone home.
Now, one of the things that disturbs me, I would say, just in the whole American healthcare system, is the rural population in Georgia. So we have a lot of counties out there that may have only one physician. It's very difficult for the inhabitants of those counties to get health care. What happens to a person, and the medical center is sort of a big mecca. People come, I'll pick an arbitrary number, from 100 miles around to come in to have the services of the place. What happens to a person from a rural county? How can the apparatus you outlined, how are those people being helped from those?
From that standpoint, we do have care transition coordinators that are located on our floor. We're very fortunate on the stroke unit. We have a very efficient one. Lane is just, to me, the best, and she makes sure that those patients have some services when they go home. We will take into consideration if a patient is coming from a rural community and maybe doesn't have as much follow-up opportunity as they would have, say, within Macon or Bibb County or Houston County, and we'll offer those patients maybe some home health or at least a couple of visits so they can go out and make sure that they've gotten their medicines filled and that they're settled in. So even if it's maybe for 1 or 2 visits, we try to make sure that they've got somebody that's followed up with them.
Now, once again, we have the disjunctions of the American healthcare system. We have all these issues, all these problems. What happens when an indigent patient appears? And we have an emergency room, so what happens in the American healthcare system is you just get to an emergency room, and no matter what your financial circumstances are, you're going to be treated. And many stroke patients are sent in from rural hospitals. They've just shown up, they've had a stroke, maybe there's no financial, I guess, resources the person has, and they're transferred to the medical center. What happens with that type of person? What happens?
We do have employees that work with those patients, whether it's to get them connected into the Medicaid system or any other type of supplemental insurance or whatever they may need that could provide them. Also, a lot of the drug companies that some of these people are not aware of will offer indigent patients medications. As long as they have a physician that they are following up with, we can fill out that paperwork and medications can be sent to the physician's offices. A lot of our medications and drug companies that are affiliated with stroke prevention medications offer cards so that the patient can go and maybe pay $4 for a medication. So that really helps them in making sure that they have the medications that they need once they go home.
I see. Well, okay, I'm happy to hear that. I think it's a big problem. We're in the stroke belt. The people that come into our hospital come from many times with strokes from rural hospitals. Now, there's a system being put in place with telemedicine, an attempt to do that. Can you discuss that? What's going on with that? What is telemedicine, and how would that help stroke patients?
There are a lot of teleneurology systems set up throughout the state of Georgia now. And what that does is, especially for the smaller hospitals that maybe can't afford to have a neurosurgeon or a neurologist on staff, or the town may be too small, the person goes to the emergency department and the cart, it's like we call them cows, computer on wheels. It's actually pushed to the bed, and we can call in, and a physician, say in Atlanta, can actually evaluate that patient with the nurse. The nurse helps doing the stroke scale and they can actually go online and look at what the CAT scan is, and that helps in quick assessment with those patients, particularly those patients that may be TPA candidates.
Well, let's discuss that. What is TPA and why is it important in stroke
TPA
care?
is very important. It's a medication that was actually approved by the FDA back in 1996, and unfortunately it was given too often and to patients that had maybe been outside the window for too long. So we had a lot of bleeding complications associated with it. Well, back in the late 1990s, early 2000s, the American Stroke Association, the National Stroke Association started doing more research into TPA and found out that if patients receive TPA, Activase or Alteplase, it has 3 names, within a 0 to 3 hour window, that these patients have a much less incidence of bleed. Actually, it's 6.4%. So we say 6.4% chance of bleed, that really means it's a 93.6% chance you won't bleed. So we try to get patients to get to the emergency room quicker. Now in 2009, the American Heart Association had done a little additional research and found that in that 3 to 4.5 hour window, patients' incidence of bleed only increases marginally from 6.4 to like 6.7%. So although it's not FDA approved, the majority of your primary stroke centers, such as medical center, and your comprehensive stroke centers actually administer the medication up to 4.5 hours. But of course, getting it 30 minutes from the onset of symptoms certainly has a better outcome than getting it at 4.5 hours.
Let's discuss that. So the idea is, I mean, they're all, stroke is sort of a generic term, so I won't belabor the point, but there are many different causes for what a layperson would call a stroke. There could be a hemorrhage, there can be a small blood clot in a particular artery, or there can be a large one in a big artery. And so the idea of giving this TPA is with the diagnosis is made that there's a large vessel that's having an occlusion, that's been occluded.
Correct.
And this is going to open the vessel up, and so presumably will restore blood flow. And the problem is that if there's already been enough tissue damage where the stroke has occurred, so the tissue is dead there, and the blood flow opens up again, there'll be a big hemorrhage because all the blood will go into this dead tissue, and many times it can be a lethal event. So It's an important issue, but I think the important thing for the public to understand is that if you have a stroke, wherever you are, if you say suddenly, well, I can't move my arm, or my face is numb, or I'm having speech difficulties, that's a big deal, and immediate attention is needed. So it's like a real 4+ emergency. So it's going to be necessary to get to a hospital very, very quickly, just as fast as possible, and every minute counts. And then what's going to happen is they're going to get a CT scan very quickly. Is that correct?
That's correct. That's the first thing that we do. The guidelines state that CAT scans have to be completed and reported back within 45 minutes of the time that the patient presents to the emergency room, because the TPA administration, that we call it the golden hour, the door to needle, must be administered within 60 minutes. That's the goal for 60 minutes. So 45 minutes to get all your testing done, and then 15 minutes to make that decision, get it mixed, and get it on board.
And so I can't emphasize enough the importance of a rapid response. A rapid response, I've seen many patients that if this didn't happen, then it would have been either death or a horrible state of disability. And if the TPA can be given, it's a miracle as to how well people do. They're totally saved. It's salvation. It's wonderful.
Right. It's a great drug. The drug was introduced as I said, in 1996, and we love to see those patients that have a complete reversal of their symptoms. That's an emergency room nurse's dream. However, the purpose behind TPA is to reduce disability by 30%. So the concept is, if the patient comes in, gets the medication, that 30, 60, 90, even out to 120 days, those patients will have a 30% less disability than they would have had they not gotten the medication. So we definitely want to get that medication on board. And kind of going back to our teleneurology, one of the things that some of the smaller hospitals can do for us is go ahead and see that patient, get the TPA on board, and then have them transferred to a comprehensive or a primary stroke center like the medical center.
And so, I mean, the story keeps going. So the idea is that, and this is a good thing, so putting this, it's extraordinary what can happen with telemedicine. There are just all kinds of great advances. And The other thing that the state of Georgia has done is they've made it, from a legal point of view, much easier for physicians to, in a distant hospital, respond to information and say, well, let's do this. And so the licensing people say, that's okay.
Right.
You're not in the same room with the patient, but you're seeing what's going on with the scan. And that's a huge deal. And that's worked well in many parts of the country. So where are we in this part of the world in putting together that kind of system, which would be a good thing? And if you're in a rural hospital, do they have access to this, or what's going on?
There are a lot of rural hospitals that already have the teleneurology. Genentech is a company that actually manufactures the TPA, and I was just speaking to the rep a couple of weeks ago, actually, and she said that there are a lot of grants that are available to some of these smaller rural hospitals that will help them fund purchase of or lease of a teleneurology cart or a teleneurology system. There's a lot of systems already set up in the state. There's things like REACH and Physicians on Call, acute care teleneurology. So there's some things that are actually available. It's best for the patient. We want to do what's best for that patient. We want that patient to get to the hospital quickly. We want them to be assessed rapidly. If they're a TPA candidate, we want that TPA on board, and then they can be transferred on to us as a primary stroke center.
And I guess so that's a really good thing. So just talking about what would be an appropriate system for the citizens in this area would be, number one is the prevention of strokes, which is a huge, big deal. And terrible things that happen with strokes, and concomitant with the strokes are heart problems. So the two go together, and peripheral vascular disease. So what's happening is the penalty for our, I guess, developed life here, excessive number of pork chops, a little extra salts, whatever.
Thursday's fried chicken.
Right, yeah, right over, just the dietary issues, maybe you're taking an extra nap as opposed to, I guess, walking to work, and not taking a bicycle. So all the system that occurs here, there's also a genetic issue. Some of our populations here may have a genetic sensitivity to this kind of thing. So we have this tremendous population at risk, and the people out there need to have a local physician that's looking after them. Right. And they need to have access to care, and they need to see a local physician or healthcare provider, to use that term. It's going to look after their weight, look after their vessels, look after their diabetic issues, and particularly pay attention to their hypertension problems. And they need to, if something is amiss, these patients need to take their medicine.
Exactly.
Out there, you take your medicine.
Definitely.
I want to hear you do what your doctor tells you out there in TV land.
Definitely.
Take your medicine. I mean, how many times have I seen people that have just not taken their hypertensive medicine? It's a terrible story.
It's a terrible story.
Once it happens, it's terrible.
And the thing that I had said earlier, we have 795,000 strokes. 87% of those strokes are ischemic strokes.
Yes.
And ischemic strokes are generally caused by controllable risk factors.
Yes.
Things like the high blood pressure, the high cholesterol, your diabetes, your obesity, your smoking, atrial fibrillation, the irregular heartbeat. So those are controllable risk factors, or at least modifiable risk factors. So if patients would take their medication, we could have a huge impact on the number of strokes.
I mean, just to keep talking about this, one of the most extraordinary things that's happened to the health of American citizens is the idea of having access to statins. So people at risk, I won't get into all the particulars. I believe a cardiologist would probably talk about this a little easier than I would as a neurosurgeon, but it's fair to say that statins have made a huge difference by changing some of the lipid profile of people in the country. So you want to have a good lipid profile, and that would reduce the chances of your arteries clogging up, and it's made a huge demographic event. It's enormous. And the life expectancy of Americans have been enormously extended. So there's a need to take that medicine under a doctor's supervision when it's indicated. So we can do a huge amount right now if we can get the citizens out there hooked up with a healthcare apparatus.
And we do make sure that our patients go home on statin. A lipid profile is one of the first things that we do because we want to make sure that LDL, that lousy kind of cholesterol, is at least below 100. If you're diabetic or had a previous stroke, it needs to be below 70. And people need to be aware of what their values are, not just what my total cholesterol is. We need patient education, and they need to be aware so that they can focus in on what they can do to reduce those risks.
Now, another thing that's out there, I guess, on the edge of treating strokes is the idea of endovascular intervention here, and that happens at the medical center.
It does happen at the medical center, and actually, I was at the International Stroke Conference in Nashville, Tennessee, back in February, and the Mr. Clean trial, which is the most recent trial, it was a Dutch trial, and there were some hospitals here in the United States. Grady was included in that participated in that study, that did promote using endovascular procedures. And for those who aren't aware of what an endovascular procedure is, if a patient has a clot that's occluding an artery, we can go ahead and give them the TPA, but they can go in and actually do what we call a mechanical embolectomy. And there's different tools. There's Mercer, Penumbra, Solitaire, Trevo. There's different devices that they actually go in, and they go in through the groin just like they do with a heart cath, and they take the device up to the clot, and they can either suck it out like with a Penumbra, or you can pull it out, and that actually helps reperfuse the brain. So those are procedures that we can do at the hospital. So just like those smaller hospitals, they can send those patients to us, and we can actually see if they're eligible for those.
So once again, it's a timing issue.
It's a very
one of the things, I would just say this, is that we have a stroke system in Georgia, and it would be easy to sort of piggyback any kind of acute treatment onto the stroke center apparatus. So getting acute treatment for anything is going to be a big important thing, and particularly for strokes. There's the idea of trauma, the so-called golden hour. So if you have a bad smash up, if you can get in there and get the bleeding under control and get you attended to very quickly after an injury, then things can be reversed. The same with strokes.
Right.
And now we have a helicopter system out there, and we have a trauma arrangement. We haven't really transported for endovascular care stroke. Too many have we? I don't think, or maybe we have.
We have transferred some.
But I mean for acute endovascular intervention, that would be what you'd think about sometimes.
Right. And
you have to go very quickly.
And they have to be very quickly. The advantage of an endovascular procedure is where TPA cutoff hours about 4.5 hours, 3 with certain restrictions or contraindications, your endovascular can go up to 6 or 8 hours. So if that patient hasn't done what they're supposed to do, like get to the emergency room as quickly as possible, then if they meet certain criteria, then they may be eligible for that endovascular procedure.
So there's a lot of good things that are taking place. There's a lot of useful research on the subject. How many patients are coming into the medical center in your sort of service, if I could say that? How many are you getting, more or less?
We saw close to 1,000 patients last year.
Wow.
So that's a huge number if you think about over a 12-month period of time of patients that come in. So when we're talking about educating the public, we want them to be aware. We want them to specifically know the FAST, the face, arm, speech, and time. The face, where we ask the patient to smile to see if there's a droop. We ask them to put their arms out in front of them to see if one drifts. And then we ask them to say a simple sentence. And we always use, "You can't teach an old dog new tricks."
Yes.
And then the T is for time. Again, getting to the emergency room as quickly as possible.
Now let me add this to that. Sometimes a person can have it's a reversible ischemic episode. So it may be that you're, I don't know, making some kind of, at the breakfast table with the family, and suddenly, Daddy, your face is drooping, and it may, after a few minutes, it may reverse itself and come back. But that's an extremely alarming thing, and it means that it's true enough, you've been returned to normality, but this is an alarming event, and this needs immediate evaluation, and that's
exactly.
You should really respond to that, any kind of issue like that.
And that's what we do. We talk to our patients about TIAs, or transient ischemic attacks. Unfortunately, the general public refers to them as mini strokes.
Yes.
But to me, I always joke with them and say that's kind of like saying you're mini pregnant. If it walks like a stroke and talks like a stroke, it's a stroke.
Yes.
But TIAs, or mini strokes, actually got coined before we had the 3D MRIs
Yes,
or the
right,
64
right.
slice
Yes,
CT
yes.
scanners. So we couldn't pick up ischemia on a film unless
Yes.
it had lasted, the
Yes,
symptoms had
yes,
lasted
yes,
24
yes.
hours. So I tell these patients, you've got to come to the hospital. Even if your symptoms have gone away, you still need to come in and let us determine if it was a true TIA.
Yes.
Because just like angina is a precursor to a heart attack, TIAs are a precursor to stroke. So patients statistically have shown that a person that has a TIA that does not get simple treatment, and treatment can be as little as an aspirin a day,
Yes.
about 28 to 30% of those patients go on to have a full-blown stroke in a year, about 20% within 90 days, and about 6 to 7% within 48 hours. So that's pretty significant. So if patients have these symptoms, they need to get them checked out. Don't wait until your husband comes home or your daughter comes home, or, oh, if it comes back, I'll go.
Yes.
Just come on in to the emergency room and let them work you up. Because those patients get admitted and they have the exact same workup as our stroke patients.
Yes. Now, one of the things that happens is that I think maybe people are nervous about coming to a big city emergency room, big city Macon, but a very busy emergency room. Oh, I'll just have to wait there. But you'll be fast tracked. I mean, anything that
Right.
people are going to look you over,
Right.
and you're not going to have to sit there all night. They're going to move expeditiously. So if you show up with these kind of complaints, you won't be sandbagged. You're going to move right along.
Right. You will be evaluated quickly by a nurse and a practitioner to determine if it's a true medical emergency.
yes.
Yes, you will.
Yes. Now, sometimes what happens, there's a bleed in the brain, and then sometimes, actually, the neurosurgeons, I'm one of them.
And then we have to call you.
That's right. We operate on that, and so we can, even if there is a bleed, there are things that can be. We have lots of additional tricks that take place. If a person has had a stroke, there are lots of things we can do. There's a whole sort of set of therapies that can be taken when a stroke occurs. And there's lots of research on the subject too. The difficulty is the brain is so sensitive, and any of the central nervous system, any of the nerves are, to any kind of blood disruption, and it's a very sensitive organ, and so we often see tragedies where if we just gone a little quicker, if the patients come in a little quicker, it would have been better.
And when we're talking about hemorrhagic type strokes, we know that the number one cause of those are hypertension, uncontrolled hypertension.
Yes.
So again, that's why it's so important, like Dr. Robinson said, to make sure that you get to a practitioner, that you get follow-up, that you get your blood pressure treated, and don't stop taking your medicine just because your blood pressure goes back to normal.
Yes. Now, is the federal government helping out with this? Is there a lot of attention to strokes? Actually, the disabilities and just the damage that strokes cause are awful.
Right.
I mean, there's a financial burden on the family, so a person can live with a stroke in a state of misery for many years.
Well, and that I'm glad you brought that up, because there is the Coverdale Stroke Registry, which is through the CDC, and I'm a member of the Georgia Stroke Professional Alliance. We have a group of stroke professionals throughout the state of Georgia. It's stroke coordinators, it's neurologists, stroke nurses in ICUs and on the floors, and we meet quarterly. We exchange protocols and pathways and order sets and policies and procedures, and we have been able through the Georgia Coverdale Stroke Registry to have advanced stroke life support classes brought to us. A lot of us are now instructors, so that we can go out to some of these smaller communities and teach this advanced stroke life support, just like your ACLS, it's ASLS. We can we can teach nurses in the smaller hospitals, rural hospitals, so that they can better pick up on, is this an acute stroke? And we also teach it to our EMS partners, because those are generally the ones first on scene. They're the
Yes.
ones that are determining, is this a stroke, is it not a stroke, where do I need to take this patient? So we certainly try to always include our EMS partners, and that's a big thing that we're actually working on with Coverdale right now, is a partnership with our EMS partners throughout the state.
Well, it sounds like you're doing great work here. As we look at the future, I'm sure there are going to be a lot of advances that take place, and it's going to be important to have a system in place so that this particular disease process is attacked from several different points of view. Let me just thank you for coming.
Well, thank
keep
you
up
so
the good
much.
work. You're doing great
Thank you.
work there,
I
and
appreciate
let's make things better for the American people.
Thank you so much. I appreciate
Thanks a
it.
lot. Thank you for having us with us, Denise.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.